Hello, and thank you for joining us for Diabetes and Chronic Disease Risk Management Strategies. This program is part of the SHRM webcast series. You can learn about upcoming and on-demand events from our e-newsletters and the webcast homepage at shrm.org/webcast. SHRM thanks the Diabetes Leadership Council and JDRF for sponsoring this program and our series of free webcasts for the HR community. I'm pleased to turn over the webcast microphone to today's panel moderators, Aaron Turner-Pfeiffer, Director of Health Policy for JRDF, and George Huntley, CEO of both the Diabetes Leadership Council and its affiliate, the Diabetes Patient Advocacy Coalition. Gentlemen, the floor is yours.
Thank you, Mike, and appreciate everybody being on today. Aaron, welcome. It's good to be with you. Just a quick introduction. Again, my name is George Huntley. I'm a patient living with type 1 diabetes. I've been an advocate for patients living with type 1 diabetes and living with diabetes for 30-some years. I'm also, in my other day job, the Chief Financial Officer of a professional services firm, and in that role, I am still the plan administrator of a self-insured employer-based health plan, have been for over 25 years. So I look forward to today's program. Aaron, tell us a little bit about the JDRF.
Sure. Again, Aaron Turner-Pfeiffer, excited to be here. Excited, George, we can do this again. I'm Director of Health Policy, and JDRF is the global leading funder of type 1 diabetes research. We're focused on finding a cure for type 1 diabetes, and in the meantime, we do a lot of research funding and efforts to make sure that the innovations that are available for those living with type 1 today are affordable and accessible. So in that capacity, in my role, I work a lot with employers, insurers, and policymakers to make sure a lot of the therapies that are available today can make it into the hands of those who need them.
Super. And we're delighted again to partner with you on this. And the Diabetes Leadership Council, everybody on our board is a past leader of a national diabetes organization. All we work on is policy issues on behalf of people with diabetes. Today's program, we're going to cover in the next hour the state of diabetes care and coverage. We're going to talk about some marketplace dynamics influencing the costs and the care within those costs, as well as having an HR perspective, plan design, ideas, tips to manage diabetes-related risks and costs. Hopefully by the end of this, you're going to have a much better understanding of what it takes to manage diabetes and some really tangible ideas that you can take to your plans to mitigate some of the risks and lower your overall costs. So with that, I'm going to turn it over to my friend Aaron to walk us through where diabetes is today and some of the stats overall.
Yeah, thank you, George. And so we'll go over some of this quickly, and we'll get into this and some of the status of the care and some of the numbers, what it looks like on the ground in our great panel here. So 1 in 8 adults today are living with diabetes, either type 1 or type 2. 37 million Americans either have type 1 or type 2. Most Americans have type 2. About 95% of folks with diabetes do have type 2 diabetes. And so type 1 diabetes makes up the minority of folks that are diagnosed. About 1 in 4 healthcare dollars are spent on diabetes or related to diabetes, and it is identified and often identified amongst large employers as one of their top drivers in their costs. And in addition to that 37 million Americans, there's almost 100 million Americans living with prediabetes, or those who are at a high level of risk of developing type 2 diabetes. So we're talking about a significant portion of our population, and likely a significant portion of those enrolled in your benefit plans. So diabetes is a chronic and progressive disease. There's no cure, but individualized diabetes management plans can prevent or delay serious complications. We know that poorly controlled or poorly managed diabetes over the term of someone's life puts them at higher risk of complications, both life-threatening complications, certainly diminishes quality of care, but also these complications are expensive. And so we're looking at here 1 in 3 folks age 40 likely developing diabetic retinopathy. Folks are 2 to 4 times more likely to have heart disease. Those new cases of kidney failure, 44% of those new cases have diabetes. Diabetes is the leading cause of kidney failure. And, folks are at an increased risk of lower limb amputation. So really serious, expensive, and more importantly, life-altering complications here if folks don't have good plans and the tools they need to manage their diabetes. So one important element here that we encourage folks to keep in mind as you're engaging in your benefit plans design is the health disparities and the inequities that exist in our system. So we know, folks, here you have Black, Indigenous, people of color versus non-Hispanic whites. BIPOC folks are more likely to be diagnosed with diabetes, they'll have a higher death rate related to diabetes, likely to have a higher rate of lower limb amputation, a higher rate of end-stage renal disease, again, leading to kidney failure. And we know that they have less access to the current standards of care specifically around types of technologies that are currently available that result in better health outcomes over time. And so there's a real distinction here, and it's important for folks to keep this in mind as you're engaging in your partners as you're building out your benefit plan. And here on the left of your screen, you can see the rates of diagnosis by different categories, and you can see on the top here, Native Americans have almost twice as likely to be diagnosed here as their non-Hispanic white counterparts. And so important distinction here because, I think this does impact health outcomes and access to care at the ground level. So I think important numbers here. I think we're all aware that inpatient hospital stays and emergency room visits are some of the most expensive, if not the most expensive, interactions that are going to happen in a plan year. 16 million visits per year, 7.8 million inpatient hospital stays. Now, keep in mind that's out of a population of 30 plus million, and not, these are likely not one person having one emergency room visit. These are likely folks who are returning to the emergency room, likely due to poor management of their diabetes. Here underneath, you can see some of the key stats. Just 50% of folks are reaching their A1C goal, 19 meeting their A1C, blood pressure, cholesterol, and their non-smoking goals, and nearly 90% having challenges with weight. We know all these are indicators of poor health outcomes, which lead to reduced quality of life, but also result in more expensive costs and more expensive plans at the employer level. Sorry, the sun is now has decided to emerge from the clouds and come right in my window here. So apologize for that. This is one I think of the more powerful slides here when we're talking to groups is and rent fans will recognize this, but out of the 525,600 minutes each year, a person with diabetes is spending less than 120 minutes with their care provider. And so diabetes is really a self-managed condition, and it's one of these places where you can have an immediate impact through your benefit design. Ensuring there are reduced barriers to accessing tools and therapies and providers is essential to helping and encouraging folks to make informed and good decisions to help manage their diabetes. And so let's move here and jump into our panel here. We've got Dr. John Anderson from First Clinic in Nashville and Donna Ryan from Ascension Health in Florida. Thank you both for joining us today. And so, Dr. Anderson, we'll start with you. You're going to tell us a little bit about your practice and kind of what you're seeing on the ground.
Great, Aaron. Thank you. Appreciate you having me on. I practice internal medicine and diabetes at the Frist Clinic in Nashville, Tennessee. And while I have tremendous expertise and experience with diabetes, I'm also a primary care provider. I mean, I see physicals. We take care of illnesses. We've had a surge of COVID here in Nashville, Tennessee. But when we talk about diabetes, and we're talking about a growing epidemic, the numbers keep getting more. I am diagnosing more patients every month. They're not getting any thinner, so obesity is a big problem here, and we're trying to deal with this. Since I started practice in 1989, though, we have some new therapies. We have some new oral agents. We have some injectables. We even have some new insulins that make a tremendous difference in the lives of our patients. Some of these SGLT2 inhibitors, these GLP-1 receptor agonist injectables, are very novel in terms of their potency, their ability to reduce weight, their ability not to cause low blood sugars. And we have new novel insulins that, because of their pharmacokinetics and pharmacodynamics, cause less blood sugar lowering as well. We even have now, associated with traditional diabetes drugs, reductions in cardiovascular events. That's heart attack, stroke, cardiovascular death, hospitalizations for heart failure, protection of the kidney with both two different types of oral agents. And we even have a new novel injectable therapy that has the best data for weight reduction and A1C reduction, that's glucose control, of any medication that we have seen yet in the type 2 diabetes landscape. So what do I have? I mean, what are my patients seeing? When they can get access to these drugs, I found that they're steadier. I have to change medicines less often. They are a durable effect. You can get these patients down and keep them down. You know that you're reducing those cardiovascular risks. But the problem is cost and access on formulary. A lot of our patients still can't get the medications that they really need. And unfortunately, I think too many decisions are being made at the pharmacy benefit manager level instead of looking at global cost. Because if a medication can reduce hospitalization for heart failure by 35%, that is way more expensive than the cost of the medications. And you pointed it out, all those ER visits, all those hospitalizations, all those things that these new therapies can reduce will more than pay for themselves when it comes to the cost of the medication. The other problem we see is even if they do have access, a lot of times they'll run out if they're a Medicare patient into that Medicare gap. We have this phenomenon that used to be at the beginning every year of non-medical switching, which wreaks havoc on a primary care office. Our patients can't get their medicines. They get frustrated. They go without for 3 to 4 months. I'm even now seeing non-medical switching happening in the middle of the year. So those are the kinds of things that are big problems for our patients. We also have new glucose monitoring devices, things called continuous glucose monitors, CGMs. They revolutionize the way you can keep control of your diabetes, look at your patterns of eating, look how your medications are working. So we've got a lot of things that we can offer patients, but cost and access is of paramount importance. So having said that, I also want to have Donna weigh in here and talk a little bit about how important education is to being available for our patients with type 2 diabetes, because as you said, this is progressive and chronic, and our patients need that ongoing support. And I'll also let her transition to talk maybe a little bit more about CGMs.
Thank you. Hi, everyone. Thanks for having me. My name is Donna Ryan. I'm a registered nurse and a registered dietitian specializing in diabetes here on the Florida Gulf Coast with Ascension, Florida. As John said, diabetes is complicated. It's not a one-size-fits-all, meaning there's not one diet, there's not one medication, there's not one tool or device or technology. So there are many different variables that impact glucose. No 2 days are alike, no 2 people are alike, and it's not easy to manage. And only 2 hours of a year are spent with your physician, if you're lucky. So this makes it really important to have not only the medical management, but that self-management education and the tools and technology to be successful. And as you can see on the slide, there are 42 factors that can cause glucoses, the blood sugars, to go up and down. Food, exercise, medication, and then biological factors like sleep and stress and hormones and smoking, all collectively and individually cause glucose fluctuations. So where does education come in? Self-management education helps people with diabetes understand and manage many of these factors, and it's key for personal success and empowerment to make the right decisions and to manage their diabetes between the doctor visits. Also, we have very clear evidence that shows that the more time, the more hours someone spends in diabetes education, the improved outcomes follow. The weight loss, blood sugars, labs, the A1C, self-confidence in making decisions. Education is key. It's an important part. And I like to say education goes beyond Dr. Google. General education is wonderful, but specialized education with your physician, with your diabetes team, and with a dietitian or nurse that specializes in diabetes is key because, again, one size doesn't fit all, and it's important to have it individualized.
No, Donna, I think that go ahead. I was going to tee you up for the next slide. I thought that was a great encapsulation of some of the technology that's so personalized, and I was wondering if you could just kind of tie in what this might look like, why it may make sense for some folks to be on a glucose monitoring system versus a pump and vice versa, or combined?
Absolutely. So diabetes technology has evolved very rapidly, and we have the data that shows that there are such great improvements in diabetes outcomes as a result of people using these technologies. The glucose monitor has been around for a long time, 30 years or longer, and has recently, in the last decade or so, really advanced to a level that we haven't seen before, which is that continuous glucose monitoring. So the traditional way of checking your glucose once, twice, 4 times a day with a meter and looking at the number has now evolved into wearing a device that reads your blood sugars constantly, and that constant 24-hour number can pop up on your smartphone, on your transmitter, and can be shared with family members. And what we see in diabetes education is that real-time biofeedback of what your blood sugars do when you eat a lot or eat things that, for example, French fries with your lunch versus French fries without your lunch. I can sit and tell you that that's a better choice to stay away from fried foods and high-calorie foods. But when people see it and we teach them how to use these devices, then that auto feedback, we see behavior changes happen almost in real time, almost immediately. So, and then that leads to blood sugars that stay more in the normal range, and that biofeedback is a really important part. Everyone with diabetes benefits from continuous glucose monitors and glucose monitoring, whether you have type 1 diabetes, type 2 diabetes, how old you are, all the data just keeps coming back. So everyone with diabetes, and especially people with diabetes on insulin, need to have access to glucose monitoring, and in particular, continuous glucose monitoring. We also see that insulin pumps, and that was another technology that's just amazing. The insulin pump mimics, it's a small device, it looks like a little PDA or a cell phone, and it's worn outside the body, and it mimics the pancreas that is making insulin, and it infuses insulin constantly over the day. And with your doctor and yourself and your team making the setting changes, what we see is glucose is staying in the normal range. So when you combine these, the glucose monitor, the continuous glucose monitor, and that insulin pump, we get close to normal blood sugars. And that's that next slide, Aaron, that you were showing. That diabetes technology is reshaping the landscape, but it's saving lives and it's improving outcomes. And all of those outcomes that you were talking about with kidney disease and cardiac, we know that the closer to normal we keep your blood sugars, the less your chance of having those outcomes. Normal blood sugars are the cause of no bad outcomes. So we're trying to get everyone as close to normal as we can. So this first graph here, what this is showing is from like 12 in the morning to 12 at night, and blood sugars that go between 50 and 300-400. And so the first graph shows blood sugars that are very variable, going up and down and up and down. That variability of going from 50 to 300 multiple times in one day is very stressful on the organs, on the vessels, and is what it drives many of those complications that we see. When we use education for the diet, for the exercise, for the things that we talked about, get the medical management, and put a CGM, a continuous glucose monitor, and manage your blood sugars, then we see that flat line. And so that's called time in range. The more we can keep someone's blood sugars in a normal range, the better the outcomes, the fewer the complications, the lower the healthcare dollar, and the better quality of life for the people living with diabetes. And so that's what we advocate for: access to medications, technology, medical care, and the education that people need to be successful.
And just briefly, let me add to what Donna said and reiterate the point that a lot of companies are putting parameters around who can and cannot get CGM now. And CGM has gotten down to a very affordable range. And as she said, simply giving somebody the feedback allows them to change behavior, and we see that their blood sugars improve. In addition to this, having a CGM, you can set low alarms features so that if a person is going to go low and have what we call hypoglycemia, their alarm can go off before they actually get very symptomatic, and they take action to treat it. This can save the potential of hundreds of thousands of dollars a year in a plan where patients end up in the ER because they were unrecognizing this low blood sugar. So again, we need access. We need our patients to have access to these technologies that are affordable, because ultimately they prove successful in terms of quality of life and in terms of cost savings.
That's a really good point.
Yeah, well said, John and Donna. And in the sake of time, I'm going to bring us to a close here. And I think what George is going to hit on this is a great segue into what George is going to talk about. Let's not be penny wise and pound foolish. I think these are investments in your employees, and it really gives them the tools they need to live, productive and well, healthy lives. And so, thank you both for joining us. And with that, I'm gonna bring in George here to segue into some of our benefits discussion.
That's great. And Aaron, thank you. And John and Donna, thank you very much for your time today and your expertise. We really appreciate it. And Aaron, thanks for leading that part of the panel and that part of the discussion. We've got a couple of questions that are in here. I'm already seeing that, how often do those who meet their diabetes care goals reduce their prescription costs and specialist needs? And we do have data to say, someone who has their blood sugars under control are statistically significantly less likely to have those complications, because the specialist needs are the complications. It's renal failure, it's seeing that kidney doc, that heart specialist, et cetera. Someone who keeps their A1C under control, their blood sugars under control, are far less likely to need that. So we know that specifically. We also know that those that we have even cost data that talks about if you are well controlled, you're gonna cost less, and I'll cover that a little in a little bit. So appreciate the questions. Keep them coming. We'll try to cover those as we go. So let's talk about marketplace dynamics and some of the things that are driving overall costs.
All the other charges earlier, but if you say I did them, I guess.
And so hopefully we can mute in the background. But rebates are driving up list prices right now. Rebates are if you look at the cost of insulin over the past decade, the cost of insulin has gone up by 143% as list price, okay, the list price of the drug. However, the net cost, which is what the plan is actually paying, has been cut more than in half, okay? It's down 54%. So that's quite a dynamic, right? List price is going through the roof, and net price is cutting in half. This is being driven by the rebate system that the pharmacy benefit manager has put in place as we move forward. So you've got a scenario where list is going up, net is going down, and by the way, competition is going up. There are more manufacturers in the insulin marketplace than ever before, which is why you're seeing things go down from a net price perspective. But the patients aren't getting this net price in many cases. So let's talk about what's happening in our system and who are the players in the pharmacy side of a health plan. So it starts with the consumer. The consumer needs to buy insulin. I've been type 1 for 39 years. I have 3 other family members with type 1, and I need to buy insulin. It's January the 1st, New Year's Day. The ball dropped, and I need to go ahead and buy my insulin in January. So I'm going to spend $330 roughly at the pharmacy, and the pharmacy is going to send about $300 of those dollars down to the drug company. And the drug company is getting $300, but they're sending $250 roughly of those dollars to the left over to the pharmacy benefit manager. So with that, pharmacy benefit manager taking $250, that's the rebate that they are charging for the privilege of being on the plan, for privilege of access to the formulary. So that money that they have received is to get access to the formulary, and then they're keeping a balance of it and sending it up to the insurance company. And that in a self-insured health plan is us on the phone. It's us on this call. So if we've got self-insured health plans, we are getting the balance and the bulk of those rebates are coming to us. But the consumer has, your participant has just paid $300 for a drug that costs $50, and that's the thing that's really important to understand. Now, we will say that we're using that extra rebate that we've received to keep everybody's premiums down. But in reality, what's happened is that it's reverse insurance. We are keeping the sick are subsidizing the healthy, and that's not how insurance is supposed to work. Insurance should be the scenario where the many help pay the cost of the unfortunate few, and that's not what's going on when we're not passing these rebates through at point of sale. So it's a lot of money, and the pharmacy benefit manager whose job it is to keep costs down is keeping costs down, but they're also having an incentive to have the higher price drug on. Yes, Aaron. You're muted, sir.
Sorry. The question might be a good time, George, just to talk about what a pharmacy benefit manager is, what their role often is, and kind of the role that they're playing both in contracting but also working with benefit administrators.
Happy to do that. So a pharmacy benefit manager is the vendor that you've hired to manage your drug plan, right? Manage your drug plan so that they are establishing the formulary. They're deciding what drugs are on your plan. They're negotiating with the manufacturers for those drugs and deciding what drugs are on your plan. And then they are also deciding what tier, from a copay perspective, those drugs fall on. So typically, and we're going to talk about this in a second, but typically there'll be a generic tier, a brand or preferred tier, and then a special, a branded tier for the non-preferred drugs, and then often plans have a specialty tier for the much more expensive drugs. So that's what the PBM's job is, to process those medical claims and the pharmaceutical claims and manage that part of the drug benefit. But they're charging a rebate for access to that formulary. And let's talk for a second about who they all are, because they're all owned by each other. So in the PBM world, you've got the OptumRx, CVS Caremark, and Express Scripts. Those first three columns on the left there. Those three have 75 to 80% of the U.S. marketplace. 75 to 80% of all of U.S. drug transactions are running by those three. And if you expand it to the next three to get to all six, you're in the 95 percentile of all U.S. drug transactions. Of note is that they're owned now by insurance companies, or in some cases they own the insurance company, but the way it's depicted, it's all in the corporate family. So United Healthcare owns OptumRx. Aetna owns CVS Caremark. Cigna owns Express Script. This is all in that corporate family. So who's keeping the rebate is less relevant in a fully insured plan because it's going up to the corporate parent. The other thing to note in here is, as you can see by the colors here, OptumRx, they also have their own specialty pharmacy and their own provider services in many cases in CVS. So when your plan has a mail order or a specialty pharmacy, and you're forcing people to go through those mail order programs, it's being done because the PBM's making more money off that. That corporate family is making more money off of it. It's not necessarily the less expensive thing. You need to look at what's more convenient for your team and for your participants. But that's what the job of the PBM is, to adjudicate the pharmacy benefit and, in theory, keep drugs down. And this is every branded drug. I used the example of insulin, but this is every branded drug out there. And so the average rebate is 48%. And so basically, if a patient is paying list price, they're paying about double what the plan is paying at net after their deductible's been met. So it's an important factor to consider as we are, going through our plan designs, et cetera. And, let's talk about our plan designs, so these are 4 very real plan design scenarios. First dollar preventive coverage, which the IRS allows, and we're going to talk about that in a second. So in a high deductible health plan, you can have first dollar preventive coverage for chronic disease management. Effective in July of 2019, they clarified that point so that you can literally bypass deductible and you can give things away if you wanted to. $25 a month, low predictable copays. That's a very common, somewhere in that $25 to $35 range. Again, you've bypassed the deductible. You're on a very predictable cost flow. Or you could be passing rebates through, and you're charging $360 net coinsurance for that drug, and that's when you need 3 or 4 or 5 different vials in a month. So you're not buying one vial, you're buying a bunch because a patient needs more than one in a month. Or if you've got no protection, you could be faced with $1,200 in January for your drugs. And we know that 69% of patients will abandon a prescription if the cost is greater than $250. So the question you have to ask yourselves if you look at your plan design is, are you training your plan participants to ration their drugs? If you're training them to bad behavior, because we know that 1 in 4 patients on insulin have rationed their drugs. We know this to be fact. So when they ration their drugs, they're going to have worse outcomes, and they're going to have a much greater likelihood of those catastrophic conditions that are so costly and so devastating for the patient. So the other thing I would point out, as we say, okay, if I'm charging $1,200 and I'm getting that rebate through, and I tell myself for some reason I think that's important, I've raised the risk to the employee in the plan. But the other thing to know about a person with diabetes is that patient is going to meet their deductible 100% of the time. So if we are overcharging our patients for our participants for their drugs, we are simply going to pay another claim prematurely. It's not as if I've gotten this extra money. I'm going to now pay that other claim prematurely because they're going to have a claim the next month. So bear in mind the true economics of the plan design structure. We also know that the cost of passing through rebates is negligible, and this is new information. We have an actuarial study released in January of this year that did the math on what would the change in the payer costs, that's our plan costs, if we did rebate pass through. And this is not just insulin, this is all drugs, all branded drugs. What would it cost? And the answer was, on a coinsurance PPO plan or a high deductible health plan, less than 1%, 0.4%. These are the 2 most common plan designs out there. 0.6% for a high deductible health plan that goes straight to coinsurance without copays. That's a negligible amount. The other thing to bear in mind in this is that this study does not reflect any major medical savings, and that was a question that came up earlier, by having healthier patients on the plan. So when people adhere to their medications, we know they save money. And Express Scripts, one of the top 3 PBMs, came out last month with a study when they capped costs for diabetes medications at $25 per month. That wasn't just rebate pass-through, that's capping costs at $25 per month, and that's all diabetes medications, not just insulin. Resulted in higher adherence, of course, to the prescriptions, but a 16.3% overall reduction in medical costs from diabetes. So the plan itself saved a bunch of money, and they did it because of reduced hospitalizations. That's what drove the savings. So investing in the pharma side results in savings in the hospitalization side. That's it's the tail wagging the dog. So let's shift to a poll here. For those, if you would be so kind does your organization offer at least one plan with rebate pass-through to plan members? Yes, no, or many of you may not know. So if you don't know, please just say that. But we would appreciate your willingness to share that information. I'm going to give folks a minute or just about a minute to go through, and I'm going to sip some tea to get my voice back here. We're going to give it just another couple of seconds. And I'm going to move us to the answer. Oops, I moved us past the answer. I didn't mean to do that. The answer was only 3% are passing through rebates. 36% weren't, and 60% are unsure. And that's normal. Unfortunately, is folks, this is not a topic that people are as tuned into, and so hopefully today's conversation will make you think about it. So appreciate your participation in that. While we're talking about the PBMs and how this cycle is working, I also want to point out that the lowest cost drug doesn't always win. The pharmacy benefit manager has an incentive, has a perverse incentive to put the highest cost drug on the plan, because the highest cost drug is the one with the highest rebate typically. And since they are keeping a slice of that rebate, they have a disincentive to put that high cost drug in the plan. You could say, oh, they're not going to do that. Well, I can assure you they are doing that. So what the data that's here is within Medicare Part D, because that's public information that we can access. Getting this information for commercial plans is difficult to get, but it's the same PBMs that are running these plans. So the same PBMs that are running the Medicare Part D formularies are running your formularies as well. In 2016 to 18, newly launched generics, savings of 30% off of their counterpart drug. Only 1 in 4 were covered in the first year. Now, why would that be? A new drug comes on the market that's going to save 30%. You would want your plan to embrace that instantly. Why isn't that on the plan the minute it gets launched and approved by the FDA and is available? Why wouldn't we want to save that money? In 2020, less than half of generic products were actually on generic tiers. Back to that, the tiering that this PBM is setting, the generic tier is the one that's the cheapest setting. It's like sometimes it's $5, $10. You really want your participants to take those generic drugs because it saves a lot of money. But the PBMs are placing those generic drugs on the same tier as the branded drug. They don't want you to take it. They don't want your people to take it. Over the last decade, that coverage dropped from 93 to 45%. That speaks volumes. CVS Caremark is being sued as we speak. This lawsuit dropped in June. It's a whistleblower lawsuit by an internal employee for preventing access to generics for senior citizens in the Medicare program. I assure you this is happening. This is something that we urge you to take a look at within your plans because you take it for granted. And it also drives really weird behavior by manufacturers. So in the insulin market, I won't spend a lot of time on this, Humalog, Novolog, and Lantus, that's Eli Lilly, Novo Nordisk, and Sanofi. These are the 3 main branded drugs, branded insulin. Yet on the Humalog, we have biosimilars, which is the closest thing you're going to get to a generic. Insulin Lispro at $82, that's Eli Lilly's own drug. Eli Lilly has, in their same manufacturing plant, goes through, puts the insulin in the same vial, puts a different label on it. Novo Nordisk on Novolog, all 3 of these in that row, made by the same manufacturer in the same plant. Why are they doing it? Because they wanted to be able to offer it at a lower price to consumers, but they had to bypass their pharmacy benefit manager contracts. So it's very, very strange behavior out there that is only there because of how the rebate practice and the rebate systems that the pharmacy benefit managers are driving. Things to note. So we touched on pre-deductible coverage, and I want to mention it one more time here. Diabetes management is preventive care, and so we would really like for you to consider this. It is anything preventive bypasses the deductible. It makes it much more affordable for patients. And so if you are considering doing that, I want to ask another poll question: does your organization offer at least one plan with first dollar coverage for diabetes management? And that's insulin, but it's also the blood glucose strips if you're doing finger sticks. If it could be other it's continuous glucose monitors. It could be pump supplies. Do you know if your organization has at least one plan that does first dollar coverage for diabetes? Yes, no, not sure. Give people just a few seconds to weigh in on that. It's kind of like listening to popcorn pop in the. All right, so here we are, and we are at 21% yes, 35% no, and 43% similar to the other one, not sure what you're doing. So appreciate that. Hopefully you'll consider thinking about that as we move on. And very quickly, I want to touch on obesity treatments. So we talked about a patient with diabetes, 89% have obesity, and we know that obesity is a big driver of type 2 diabetes. It's also a big driver of overall healthcare costs, $170 billion in excess expenditures every year. It was a driver of bad COVID outcomes, hospitalizations, costs, et cetera. In Medicare Part D, when it was created in 2006, there were no FDA-approved obesity medicines. So Congress specifically excluded obesity drugs from Part D. And as a result, many of the commercial plans today, your plans, our plans, are not covering obesity medications, but there are many medications and several medications that are now on the market that are that work, that are effective anti-obesity meds, which you probably or may not be covering. And I bring this out because it's a lot cheaper to address the condition than to pay for the complications of diabetes. Diabetes itself a person with diabetes costs 2.3 times more than a person without. Your plan will likely pay for gastric bypass surgery, but you may not be paying for the medications that you could be on to avoid having the expense of that surgery, because that surgery is absolutely not cheap. So I urge you to consider that in your plan design as well. So I now like to invite my friend Rich Musti to join, and we'll have a quick conversation on plan design. While Rich is turning his camera on and unmuting himself, Rich is the president and owner of Unified Group Services. It's a privately held third-party administrator for self-funded group health plans. In full disclosure, Theorist Group, which is my other day job company, we use UGS and have been a very happy client and have been pleased to work with Rich for many years now. Rich, why don't you tell us a little bit about Unified Group Services, how you started, and just give us a little bit of the dynamics of your clients and your own team.
Okay, I've been in the industry for 30 plus years. Founded Unified 26 years ago, and specifically connected and worked directly, as you said, George, with people like yourself. We take it very serious in trying to help them control their health plan cost, remaining adaptive to new things in the industry, and trying to manage self-insured healthcare plans. That's what we do all day, every day. We're not into fully insured plans. It's managing health plans, and we're obviously considered a payer using other people's money, which is our customers. So we're looking at every angle from a medical perspective. And as of the last several years, concentrated very heavily on the prescription side, and the topic of diabetes, like you're talking, as well, especially medication management, and particularly the management of the cost of that. So we work with various size plans. Our average customer has probably 250 employees, and we're very nimble in the market and handle in the neighborhood of about 70,000 covered lives, to the tune of $800 to almost $1 billion a year in managed healthcare costs.
Thank you, and we fit right in that sweet spot for you guys. I know we've had conversations. You've helped us define or develop our health plan, where Theris is passing rebates through at point of sale to employees. Can you tell us a little bit about how you handle that for Unified and some of your other clients, and what drove you there?
Yeah, and really, George, and it's going to be kind of hard to believe because that percentage that came up was surprising of lack of rebates passed along at point of sale to customers. We're approaching our 20th year of deploying rebates at time of purchase. So what drove us was the fact of a change in direction and trying to be creative and help our customers. And one of the things was on the RX piece, obviously, it's continued to be a huge growing cost. So we have the majority of our clients are under that type program, probably 70 to 80% of our customers. We have 160 self-insured customers. And again, about 80% call it deploy rebates at point of sale. And the others that do not would be our distribution channels. This is something that for most people, I think, to hear in the audience out there, our distribution channel is through brokers, consultants, agent, whatever they call themselves, out in the market. And kind of a quagmire that we're in, there's situations where they bring a PBM to the table on behalf of the customer, and Unified doesn't bring in the pharmacy benefit manager, and many a times they will place that pharmacy piece with a PBM that does not deploy rebates at point of sale, much to our frustration, because we know the savings for our clients and particularly the employee participants. And reason being, those agents and consultants, many of them are used to just working with the big names that you mentioned, the Cignas, Blue Cross, United Healthcare, that really control the pharmacy piece and the PBM so that they partake in the rebates in some fashion or other. Sometimes they don't give any rebates back, which takes 9 months to a year, and sometimes they share in that, but there's hidden numbers versus our model is 100% disclosure and deployment at point of sale. And if you don't mind, I'd like to share real quick just a couple of prescriptions. For example, Janimet used for diabetic medication. Our customers, the traditional cost at pharmacy is $1,474, but our customers pay $1,009. This is the last year's average. So the rebate was $465 on thousands of purchases. So the net cost was right at $1,000 instead of $1,474. So the employee pays whatever copay of that, but then the rest is passed along to the employer as we bill them on a weekly basis for claims. So the employee and employer recognize that saving on an instantaneous basis. And I think people would be surprised, but we have many clients that the rebates average out to almost $100 per employee per month in savings that is taken advantage of, again, at point of sale.
Yeah, and those are compelling numbers from a patient cost perspective. And do you have difficulty getting the PBMs to do this, or you know which ones work?
Right. There's a handful out there, George, and we work with just a chosen few just to streamline the business processes. And some of them, they kind of wear that model on their chest, so to speak, and it's like clockwork, and it's not even a question. They know that as we add customers with them, that will be the model that's in place. It's not a one-off situation. It's the mainstream way of doing business.
Yeah. Well, we certainly appreciate that very, very much. And I think it's important to hear, because we know that all of the PBMs will do it. It's a question of it's rarely their lead card. And
George, can I let me interrupt you for a second, George? If those say that they will do it on an ask basis, I'm confident that it's not a 100% deployment, and they're getting a piece of that pie. Ours is a 100% Unified as a payer. gets none of that rebate, zero. We don't participate in the claim savings. That's 100% pass through, and it's helped us tremendously compete in the market. And we're fortunate as an administrator to continue to grow and compete very favorably, and very thankful for that.
Oh, appreciate that very much. And it is an important distinction. I think this is an area where the transparency is not there. I mean, we have a lot of discussion around, the transparency. When you're in the major medical side of a health plan, you get an explanation of benefits as a patient, as a participant, and that explanation of benefits will tell you what what the doctor charged, what the hospital charged, and what the plan discount was, and what your piece was. But in the pharmacy side, you don't typically get that, and having somebody looking out and really focusing on making sure that you're getting those rebates. And I back to the people on this presentation, making sure that you are actually getting the value of those rebates for your organization, and they're getting passed through to your people and your participants at point of sale, especially in the deductible period of time. Why would the insurance company make a profit when I'm during my deductible period? That doesn't make sense. Well,
right,
Rich, I really appreciate your being with us today and being on this. And I want to offer you, if there's anything that I haven't asked you that you wanted to share.
Well, real quickly, George, there's so many moving parts that easily, understandably, an employer would be confused in how to attack this pharmacy cost. And it really rolling up your shirt sleeves and taking a very creative and aggressive approach that we do, especially medication piece. We've saved our clients millions of dollars on the specialty side, but yet the employees have gotten their prescriptions through the foundation efforts that we have. And I guess a final note I'd like to make, I looked at our block of business, and it's about $100 million spend annually on our combined customers in prescription cost. And this last year, again, across the board, we had a negative 6% trend on our book of business from a pharmacy perspective. And that comes from point of sale rebates, but also specialty medication and deploying these preventative meds. We have a lot of customers that are allowing preventative meds, even if they have a high deductible health care plan, and paying for those ahead of time before they meet their deductible. So I'm just sharing that with you guys and anybody that a lot of work can be had, but a lot of success that we're having, and a negative 6% trend is pretty unique for the market.
I think everybody on this call is going to be hopefully suitably impressed by a negative 6% trend, given everything else that's going on. I don't think many people can say that their healthcare spend is dropping overall in any area, much less drugs. So that's impressive.
Well, hey, thanks for having me on, George, and look forward to continued dialogue.
Much appreciated, Rich. Thank you so much for your time. Much appreciated.
All righty. We'll see you. Thank you.
Thank you.
Bye.
So we're going to move on as we're getting nearing the top of the hour. So we know that from an Employee Benefits Research Institute study, 76% of plans expanded pre-deductible coverage when they heard that the IRS allowed that in a high deductible health plan. So that's an important thing. Cost sharing, 30% waived patient cost sharing on insulin and other glucose lowering agents. These are things that we urge you to consider. These slides will be available for you. They make sense for the employer. They make sense for the employee. We're going to talk about some bonus features here. Continuity of care, rather than annual medication changes. You heard Dr. Anderson talk about non-medical switching happening even in the middle of the year. The more you mess with a participant's a chronic disease patient's medications, it's hard enough to get stable, much less to have them change medications annually because you've had a change in your participation. So there are a lot of things here that you can be considering. I know we're getting near the top of the hour, but we urge fast adjudication of diabetes claims. Make sure that education is covered in your plan. Minimize the spread on generics, and make sure your generic drugs are actually on the generic tier so that people have access to them. And make sure that your plan design and your guides are in a way that a patient with diabetes can understand how things are going to cost when they're in their open enrollment period. I'm going to move us to another poll question, if you would help me out. After viewing this webcast, are you more likely to consider passing rebates through to plan participants at point of sale? You've now heard us talk about this for quite a bit, and other things in addition to rebates, but based on this information and the actuarial study and the fact that we've got so many people now we know doing it, are you more likely to think about it yourselves? I'll give folks a minute or so to go through this. We appreciate your participation in this very much. We're getting we'll push that through and say, super, I appreciate that. 91% said yes. A couple of folks are still doubting Thomas's, and a few were already doing it. So we appreciate that as well. Again, very much appreciate your attention to this. Aaron, I'll invite you back, and then Mike, if there are questions that we perhaps didn't answer or that we can put out there in the last 60 seconds.
Well, I do think we need to begin to bring the program to a close. Let me just ask you all if there's any closing remarks you want to make. We are coming up to the top of the hour. We do have a couple of announcements for folks, but why don't you finish with some closing remarks?
Aaron, any from your side?
No, I think appreciate folks' attention on this. I think there are, as George has laid out, there are opportunities to really drive better health for your employees with diabetes through better benefit design. And so we're excited that you all are engaged in this way and appreciate your time and attention on this.
Agreed. Really appreciate your time. And Aaron and your and everybody on the panels, thank you for your time. JDRF, thank you for your partnership. We appreciate it. And SHRM, thank you for facilitating this. Mike, really appreciate it.
This program is sponsored by the Diabetes Leadership Council and JDRF. The Diabetes Leadership Council is a patient advocacy organization whose members are individuals with decades of diabetes experience and leadership who work to advance patients-first policies related to diabetes at the local, state, and national levels by engaging policymakers and public and private sector influencers. JDRF is leading the fight against type 1 diabetes by funding cures research, advocating for policies that accelerate access to new therapies, and providing support for network for millions of people around the world impacted by type 1 diabetes. Both organizations work to educate employers on health plan design options that lower their plan risk and costs while improving employee health. Learn more at diabetesleadership.org and jdrf.org. Before we sign off, we want to thank today's distinguished panel for the information that they provided today. We also want to thank everyone tuning in for being with us and for choosing SHRM for HR webcasts. That concludes this program.